Yes, 2.5 trillion naira is what the healthcare and social welfare will get in 2025 budget out of the headline figure of 55 trillion naira. Hello, everyone, and welcome back to the show. This is the KPMG Arise News Budget Day 2025. With my panel, healthcare. Health is wealth. So let's be introduced to my panel. Dr. Kelechi Ohiri, who is Director General National Health Insurance Authority. Thank you very much. Good morning.
Good morning.
Welcome to the program. And of course, Fola, Laoye, CEO, Wilson Investments. Thank you very much. It's good to have you here.
Thank you.
And the first female on the panel. Thank you very much, madam.
Great.
So I'm going to start with you.
Okay.
And don't get jealous. This is it. 2.5 trillion for the budget. How do you consider that size? Is it big enough? Is it large enough?
I think it's definitely a step in the right direction. It's double the budget of last year. So certainly we're very, very happy to see this commitment from the government side. We still have some miles to go though. We always have in our sights the Abuja Declaration, which is 15% of budget, but we're making great strides in that direction.
Since the announcement was made and since Mr. President signed that, what has been the discussions within the healthcare sector, in the private sector, what the direction should be for this year as far as budget for the healthcare and social welfare should go? What are your folks, your colleagues and professionals in the industry talking about?
I think for us, it's more than just the budget, more than just the funding, but it's also really the direction, the amount of commitment and political will that the government is showing, which is significant. In addition to increased funding, there is, of course, some key elements like the presidential initiative on driving the value chain in healthcare, PVAC, which just a few days ago actually has had some major pronouncements of local manufacturing and supporting the purchase of local manufacturers of drugs and consumables. So that is already bringing us, a significant lifeline into the healthcare sector, because we see it as one, obviously being able to help us really create what we call a local system, which reduces costs significantly compared to what we have to spend on imports and tariffs and so on. But secondly, also, of course, it provides jobs and it really creates, some significant, shall I say, mobilization of resources, even from the private sector.
Interesting. You win my heart. Again, because it comes to domesticating, localizing the healthcare infrastructure, the vaccines, everything from syringes, everything that we need locally. And we can do a whole lot. And I'm sure you agree. But what specific outcomes do you think, how much do you think we can deliver from this 2.4 trillion naira from the government?
Thank you very much, and thanks for having me. And I think as Fola mentioned, one element is the quantum. The second element is what is actually directed at. And I think we have a policy framework, which is a health strategy renewal and investment initiative, where we're looking at governance. So how do we create more efficiencies by making sure that we all have an alignment? Nigeria has a mixed healthcare system, which means it involves both the public and the private sector. So through a sector-wide approach, what the minister has done is making sure that there's alignment across all the subsectors in the health sector to actually improve outcomes. The second element of that is the pro-poor nature of the budget. The Basic Healthcare Provision Fund, which is a major equity intervention that commits 1% of the consolidated revenue towards the poor, has doubled against the last year. I think it was from about 144 billion to about 290 billion this year. And so what that does on the supply side is that it targets primary care, which is the foundation of any health system. And on the demand side, it makes sure that we can provide insurance coverage for the poor and the most vulnerable in our society. Fola has also talked about the PVAC program, where from a policy perspective, we know that we need to unlock the market potential of the private sector across the value chain. Now, I head the National Health Insurance Authority, and in the last year, we had an additional 2.7 million people who were covered. So a significant part of what we're focusing on this year is how do we expand coverage, enforce that mandate, but also make sure that as we realize universality in healthcare, that the poor are also carried along in the process. So it's not just the amount, but it's also the clear, intentional, strategic directions to make sure that we unlock the private sector, we have coherence in policy and governance, but also that there's a strong equity mandate that builds from the bottom up in primary healthcare. I think in addition, the other thing that we've seen in the budget is a lot of investment in healthcare infrastructure, whether it's cancer centers, working with the teaching hospitals. And the government recognizes that the government shouldn't do this alone. So it's leveraging other PPP models, such as the Cancer Center, University of Lagos, with the NSIA that has been done to ensure that we can expand this across the country. So that coherence and consistency in policy direction is one of the key things to observe in this year's budget.
How much would you like to see from our overarching healthcare policies of the government to drive technology innovations, to drive public-private partnerships, just about the NSI investing in some of our sovereign wealth funds in cancer and various places, and then about policy reforms. 2.4, 2.3 trillion, double that, if not enough for 250 million of us. So we need a whole lot more private sector on the ground than what the government alone can deliver. So how much more would you like to see in 2035 beyond the figure, the budgetary figure?
No, certainly it is the reform, it is the policy direction, it is really the embracing of the private sector. In fact, most recently we've been calling it that we are shifting now from just public-private partnership to public-private integration. That how does the government now really work to integrate what the private sector can bring? And we're beginning to see that quite significant steps. Apart from on the local manufacturing side, I mean, Kelechi, of course, even just being here and sitting here with me is showing the collaboration that certainly the need for growth of what I'll call the demand side. We really need to create a healthcare market. I mean, we've seen other countries do it. I mean, very recently we saw what was going on in Indonesia, which is a very similar sort of economy to ours, where they have really gotten to what you call 94% coverage of 250 million people in their health insurance system. Now, imagine that we really have a much more robust health insurance system, which really brings what I'll call risk pools to the table, which brings as many as we can into the table. Then the access is there, and it really works with the private sector in investing, in bringing investments, in creating more infrastructure, in creating more supply, not just in terms of manufacturing, but service provision. Again, of course, one of the key issues we're facing now in service provision is the loss of talent, the Japa syndrome, which has really hit us. But we know that the more there is a market here, the more we can see skills being retained in country. So certainly the policy framework, and of course the policy framework around technology is key. Again, the use of telemedicine, we're seeing, of course, because we have such a strong digital mindset in this government, we're seeing, again, conversations around how do you really push digitization of healthcare and, the data collection and so on. And then don't forget, of course, we've just come out of a pandemic where data was key, of us really being able to be sure that we had a robust sort of healthcare data collection system. So all of that is...
Very interesting. How much of what the lessons from COVID-19, and I'm sure we all went haywire, as it were, and it was as bad as it can get. Then we've got institutions such as the African Union, the African Bank, and a few others, talking about, look, we need to domesticate vaccine production in Africa. Nigeria was selected as one of the, we have a medical center supported by African Bank in Abuja and a few others, the Center of Excellence. That's what Nigeria was designated, and a pass mark for Nigeria there. So how much of this involving universities to do research and all of that? Are we still onboarding all of that in terms of healthcare spending for this year and perhaps beyond? Is that still on Dr. Ali Pati's front burner?
Absolutely. And I think when we reflect on the lessons learned from COVID, there are a few things that came out of it. And I think one was the need to depend less on the global supply chain, and hence the focus on domestication of our manufacturing, of commodities, of supplies, of drugs, and eventually vaccines. It's a bit more complicated making biologics, but I think we're on the right path to that point. But there's a bigger question in terms of when you look at the global health architecture and you look at the dependency that many countries have on global health financing, for instance. Recently, a lot of countries were stunned when the US government had a policy shift and USAID suspended operations, and you also saw other leading donors reduce their overseas development assistance.
How do you feel about that?
Well, first, I think we are grateful for the support they have provided over the years. Lives have been saved as a result of that. But secondly, every country has a responsibility to its citizens. It's a duty we cannot abdicate.
You think it's a wake-up call?
Oh, absolutely. But I
Perhaps
think
we
Nigeria...
saw that coming. So we raised the budget this year.
Well, Nigeria at least responded very quickly and rapidly. So whereas maybe in other climes, people might still be in shock, in Nigeria, there was a very quick response. The minister convened the team. We did the bottom-up costing. We looked at the gap analysis, and immediately actions were undertaken. First thing was do no harm, make sure that we mitigate the impact, that those that are on life-saving medications do not suffer. Secondly, we looked at the systems that were being created. So things like the health workers, they've all been absorbed. And then thirdly, we're looking for more efficient ways of providing access to services. And it's also an opportunity for us to look at that. And so it's a wake-up call, not just for Nigeria, but for everyone. But I think it's in tandem and in keeping with the strategic direction we are undertaking as a nation, which is that of domesticating the way we actually intervene in our health systems from the demand side as well as on the supply side. And so you can see that coherence. And maybe that's why Nigeria responded much more quickly and more robustly than many countries in the same situation.
Fola, do we still have enough and qualified medical professionals in Nigeria to take care of those that we lost over the recent years to the Japa syndrome? Do you still think, based on industry realities, do we still have those that can step in? Because again, with the challenges we have before, the population is on the rise. We're seeing pressure on public and private hospitals in terms of folks who are there on a daily basis, whether they want to do high tests. A particular individual went to do, an elderly woman went to do a particular, at the general hospital, they said there were 10 folks there before that were to attend to them. That was last week, Friday, there were only 2 left. 8 had Japa. So all the folks who were pouring in had to be attended to by just 2 individual professionals. So do you think we have those who can fill those spaces?
I think
How can we stimulate them through the private sector?
Yeah, I think what's important is the pipeline, in ensuring that we still have the pipeline of those who are being trained to, continue being trained. We certainly have, several number of medical schools across the country. We certainly have seen, this minister and this government already also begin to work on increasing that. We've also seen even state governments, for instance, in Lagos State, where there is now an up-and-coming university for in the medical technology and science. So the training pipeline is critical. The training pipeline also at what I'll call the specialist level. So making sure we're getting enough postgraduate training happening in the country is also critical. But the other thing too we mustn't forget is the diaspora that we have. The sheer size of the healthcare diasporans, as I like to call them. And we're not alone. There are many other countries who have been through this, and there are many other countries who are going through this now. If I pick India specifically, India also really grew their own healthcare system by focusing very much on bringing the diasporan Indian doctors from around the world back into the country. And that was, such a game changer. And I believe that we have that opportunity here as well. And in fact, if anything, we have the best of both worlds. A lot of them have trained here, they know the country, they are committed, and so on, and yet have had the best experience globally. So really being able to bring them in and work with also the growth of the local talent is going to be really important going forward.
Very, very interesting point. Dr. Ohiri, the government is liberalizing governance, so devolving a whole lot of things to the local governments at the bottom of the pyramid. Do you think primary healthcare should also be devolved back to local governments to make it easy for folks to get medications, whatever they can get at affordable cost and easily down there?
I think primary healthcare has always been something that's has been implemented at the local government level. health has been on the concurrent list where typically for service provision, basic primary care is at the local government level, and secondary care at the state level, and then tertiary care at the federal level. Now, in many states, in order to create efficiencies, they had something called primary care under one roof, where the state government and the local governments partnered to ensure that not only is care provided at the primary care level, but that there were effective referral systems to sort of general hospitals, etc. Now, I think it's best practice that care is brought as close to the community as possible, which means that the primary care centers have clear links and they are community driven, because elements of that will involve health education, outreach to the communities, working within community structures, and the local governments is more equipped to deal with those things in their communities. However, there has to be some accountability and oversight, and that's where the local governments now need to ensure that the facilities are fit for purpose, working with agencies like the NPHCDA. It means that the primary healthcare center has to have, one, the right health workforce, and these need not be doctors. They could be nurses, midwives, community health workers. It needs to have commodities so that when people show up there, the basic essential commodities are there. The service delivery points have to have the basic infrastructure so that people are treated with dignity. And in addition to that, there has to be services in the communities because not everybody will show up at the primary care center. So that is what brings up the primary healthcare system that we have. So I think it's a good thing that we're holding different levels of government accountable for things that they are best placed to actually provide. But we shouldn't look at the system in a balkanized manner. It's one entire system. And so the linkages between primary, secondary, and tertiary also needs to be strengthened. For instance, in the program the minister is driving on crashing maternal mortality, it starts from a woman in the community being able to access basic ANC care. And if there are complications and problems, being able to be referred to a secondary care where the program the government is driving on free access to maternal care means that when you show up with that complication, ability to pay is not going to be a barrier. So that requires synergies between the primary care centers and the secondary and tertiary facilities.
So can we use this model, as it were, with social welfare in terms of not just a bottom-down approach? Well, the big money will come from up, but in terms of how we implement it, we use a bottom-up rather than up-down approach. Do you think that can be done to internalize some of this social welfare so that it gets to the vulnerables that we really determine it to be, and they don't end up in some warehouses? I don't want to name names.
Certainly, it's really important. As Kelechi has said, care, it starts in the community, always needs to. Whether it is public health or private health, it always, you have a cough, you have a cold, your child seems to have a fever, you want to go and get the care as close as possible.
And social welfare as well.
So certainly, and social welfare builds into that. Once that structure is in place, once that community structure is really in place, then of course, we still need to work with government in terms of subsidizing care. And that's very important. I know that we have tried in a few ways to see subsidies for care come through, again, the demand side through health insurance, because that's a way of government also knowing, as you said, that you can measure what you're buying, what you're paying for. You can measure, you can see the outcomes, you can see the services, you can see the women, the children, and all members of the family being looked after. So certainly, having the structure in place and then having the subsidies are both critical.
All right. Very nice speaking with both of you. I have a question. I'm proposing to the government that there should be a $50 social welfare given to families in Nigeria every month. And I'm wondering, who should it be given to, the husband or the wife?
You know where I'm going to go with that now? And let me finish the response.
Okay. We know the answer. We know the answer.
Not only because, of course, women are the very much the ones who look after the entire family, but of course because they also look after the children, so they also try to ensure that there's food on the table.
You lost. Dr.
I totally agree.
It wasn't fast
Don't
enough.
protest. Don't protest. Don't protest. Don't protest. Don't protest. Don't protest. Thank you so much.
No
It's good
protest.
having you here, Dr. Patrick Ohiri and Dr. Fola Laoye. Thank you so much.
Thank
it's good
you.
to have both of you here. And discussing health. Well, you got to listen to the next session. And that's tax. The tax man is here. And he's sitting down with Rosa Sodiri, my colleague. We'll be right back. This is your KPMG Arise 2025 Budget Day. We'll be right back, everyone.